What's up, Ninja Nerds? In this video today, we're going to be talking about cardiac tamponade. If you guys like this video, it makes sense, you enjoy it, please support us by hitting that like button, commenting down in the comment section, and please subscribe. Also, down in the description box, we have links to our website where you guys can check out some awesome notes and illustrations to follow along with during this lecture. Let's talk about cardiac tamponade. So cardiac tamponade is a very disastrous, scary condition that if you ever see it, you'll never forget it. In this condition, it is when someone has a rapid accumulation of fluid, whether that be blood, whether that be serous or serous-sanguinous fluid, that accumulates within the pericardial cavity rapidly. And if it slowly accumulates, it also gets to the point where the fluid is so much that the pericardium can't stretch anymore, that what happens is the pressure in the pericardial cavity gets so high, it starts to squeeze on the heart and reduce the filling of the heart. And that can lead to some catastrophic effects, especially cardiogenic shock. So let's talk about that. So what I want you to understand is that there is a big difference between someone having what's called a pericardial effusion and what's called cardiac tamponade. These are not the same, okay? So pericardial effusion, tamponade, they both can have fluid that's accumulating, right? So when we actually say, what is the similarities between them? Because they technically aren't the same when it comes to the entire catastrophic process. It's really the physiology between them that's the difference. But the similarities between them is that they both can have some type of fluid that accumulates within the pericardial cavity. So there's some type of fluid. And that fluid, it could be blood. And the blood ones are the scary ones because those are the ones that rapidly accumulate and can lead to cardiac tamponade. But it also could be some type of serous or a serous-sanguinous. And in these conditions, we got to be able to understand the differences between these two. So whenever there's blood that's occurring within the pericardial cavity, we call that a hemopericardium. And there's particular causes that we have to be able to understand what can lead to these hemopericardiums. And then we'll talk about the combination of serous and serous-sanguinous. And in these, we actually have already talked about this. If you guys have already watched our video on pericarditis and pericardial effusions, it's all the particular causes of pericarditis and pericardial effusions. Now, let's briefly go over what are the particular causes of someone having a hemopericardium, blood that's accumulating within their pericardial cavity, or serous or serous-sanguinous effusions. And then once we've covered all of those causes, what we'll really establish is what is the true definition of cardiac tamponade and how can we truly differentiate that from a pericardial effusion. So let's go through these causes. The first one for hemopericardium is when your left ventricle has undergone some type of infarction. So in other words, you've had an MI. Now, post-MI is the issue. Whenever somebody has an MI, they actually have an infarction, right? So let's say that this area of the left ventricle has infarcted. When it infarcts, what happens is you try to lay down a tissue to allow for there to be some kind of healing process. So let's say this is the area that's infarcted. You lay down a tissue, it's called granulation tissue. The problem with granulation tissue is that it's very weak. And because of that, it kind of thins out this actual myocardial area that's infarcted. The problem with that is that if you build up enough pressure within this left ventricular cavity and just explode your left ventricle open right into the pericardial cavity, oh my gosh, could you imagine this? Blood is just going to squirt right into the pericardial cavity. So post-MI, one of the scariest situations that you probably never see because these patients will likely progress to cardiac arrest is when they have what's called a left ventricular wall rupture. That can cause a massive and rapidly accumulating hemopericardium that can quickly develop tamponade. What's another one? This one's actually relatively easy. Imagine you poke a hole. You poke a hole in the atria, boom, blood's gonna just squirt right into that pericardial cavity. You poke a hole into the ventricle, boom, blood can actually squirt right into that pericardial cavity. So some type of trauma is definitely one to relatively easily make sense of, especially if it's a penetrating trauma and that penetrating source was removed. And you stab somebody, you remove it, then you just open up a hole, it's just like a little leak, boom, blood's gonna go right into that pericardial cavity. So these are two. What are the other two that I want you guys to remember for hemopericardium? All right, what's another particular cause? Another one is called an aortic dissection. And this would be like one of the more proximal aortic dissections. So you have your blood from your left ventricle getting pumped up into the aorta, right? That's the design destination of where you want it to go. But for whatever reason, there's some weakening of the intimal lining, right? Maybe this is because of smoking, hypertension, atherosclerosis, whatever it may be. Your blood actually channels right between there, that intimal tear. And then when it goes through the intimal tear, it tracks between the intima and the media. Let's say it tracks retrogradely. Oh shoot, son. And when it tracks retrogradely, it just empties right into the pericardial cavity. And then blood rapidly accumulates into the pericardial cavity from this arterial source. That could also lead to a rapidly accumulating hemopericardium. What's the last one? This one is actually some type of cardiac surgery. I mean, think about it intuitively, right? It's always something that's going to be, causing injury to the heart. If you are doing something like you're trying to repair a valve, right? So you're trying to repair a valve, and during that process of repairing the valve, you produce a small, injury to the actual atrial wall or to a small vessel that's around that area, like the left circumflex, and boom, blood just leaks into that pericardial cavity. That can be problematic. You're trying to do some type of percutaneous coronary intervention. So you're threading the catheter through there and you just, you're hitting a lot of resistance. All of a sudden you just decide to, boom, blast right through it and blood just empties right into the pericardial cavity. You're doing a cabbage and one of the grafts are leaking, or you hit some type of large structure during that cabbage and boom, blood leaks into the pericardial cavity. Or you're doing some type of ablation. Sometimes if patients, you want to ablate like the AV node and you're trying to hit it with radio frequency waves, maybe for some reason when you're doing that, you hit like an area near like the posterior part or something near that area, and boom, blood can just dissect right into that pericardial cavity. So you can see this in situations like valvular surgeries and some type of cabbage, percutaneous coronary intervention, or radio frequency ablations. So these are big things to think about for hemopericardiums. These are the scary ones because they rapidly accumulate. Let's talk about the serous and serosanguinous effusions. All right, so now let's talk about the other particular causes of someone developing cardiac tamponade. So serosanguinous. In these conditions, I don't really want to go through all of these and list every single cause. All you got to do is remember all the things for pericarditis, my friends. So in these situations, it's got to be some type of infectious lesion. So an infectious etiology. If you guys really want me to do that, guess what they could be? Viral, more likely the cause. So Coxsackie-B virus, SARS-CoV-2 virus, right? Or bacterial infections such as Staphylococcus aureus, Streptococcus pneumonia, Mycobacterium tuberculosis. The bacterial etiologies, again, you would see these more likely in someone who's had some type of recent cardiac surgery or thoracic surgery, that you've opened up the actual chest cavity and allowed for bacteria to enter in. Viral, again, you might see some type of respiratory tract symptoms, low-grade fevers. And the bacteria, you'll see high-grade fevers and septic appearing. Now, these are the big things to remember. Now, what else could be some other particular etiologies here? It may not just be infectious. And again, what's the actual most common cause of pericarditis? Idiopathic. And so we don't know why, but guess what we suspect it to be due to when it's idiopathic? Infectious. And you know what the most common infectious cause is? Viral. The other particular causes that we want to think about that can cause pericarditis and subsequent pericardial effusions that are serous and serosanguinous in nature is neoplasias. So particular types of neoplasias, because what can happen is these neoplasias can actually cause metastasis from the primary cancer to the pericardial tissues. And so what are these? You have a lung cancer, you have lymphoma, renal cell carcinoma, or breast cancer. So what else could it be besides someone having some type of primary cancer where it metastasizes? It could also be, when someone has chronic kidney disease, like particularly when I say chronic kidney disease, they're like end-stage renal disease on hemodialysis, or they have an intense acute kidney injury. The overarching theme behind these two is that usually this leads to excessively high urea levels in the blood to where it actually causes like manifestations, clinical manifestations, and we call this uremia. So that's another particular etiology. So we have infectious causes, neoplastic causes, uremia. What's another particular one? Another particular one here could be some type of autoimmune process. And so when I say autoimmune, this would be more likely what? This may be a patient who has some type of systemic lupus erythematosus, some type of rheumatoid arthritis. And these conditions, these are the ones that I want you to think about, because these are more likely to be the ones that causes a serous or serosanguinous type of pericardial effusion that usually are more slowly in accumulation. But once they get to a very large volume to where the actual pericardium can't stretch anymore, guess what? It can lead to tamponade. There is other ones that I can mention here, but these are the big ones that I don't want you guys to forget. So now, what's the question that I have for you guys is, how do these particular etiologies lead to pericardial effusions? Well, if you guys watch the pericarditis video, either way, whether it be an infectious etiology, that's going to damage the pericardium. Whether there be neoplasias, where you have some type of primary cancer and it metastasizes and spreads to the pericardium, that's going to also cause inflammation of the pericardium. Whether there's urea that's accumulating within the pericardium, or there's autoantibodies that are destroying the pericardium. Either way, there's inflammation. With this inflammation of the pericardium, there's lots of cytokines that are released. You know, these cytokines are like prostaglandins and histamines and all these molecules. You know what they do? They travel to the local capillaries nearby and they say, hey baby, why don't you go ahead and dilate and become more permeable? And what happens is these vessels become more permeable and fluid starts leaking into this pericardium and into the actual cavity. And so you get pericarditis, inflammation of the pericardium, and you subsequently get all this fluid that accumulates within the pericardial cavity, leading to pericardial effusions. Now, if this effusion accumulates and it gets really big, and there's also subsequent inflammation, what would that look like, my friends? Come down here and let's take a lookie. So out of all this process, right, so you have that accumulation, right? So you have this effusion, you have this pericarditis. What could that actually look like eventually? So here's your normal. So this is a normal heart, right? And what happens is you get all of these actual causes that lead to inflammation of the pericardium and subsequent pericardial effusion. And then what happens is you get all of this fluid here. So all of this is your effusion. This is all the effusion. And then you also have some inflammation of the pericardium via, what is this called? Pericarditis. The question that you guys should be asking is, how is this not tamponade? What is the difference? I still may be struggling a little bit, Zach, to understand what the true definition is and the differences between someone having an effusion and someone having tamponade. Well, the big arching theme here is that this fluid is going to start squeezing on the heart. And when it squeezes on the heart, it's going to reduce the actual inflow of blood into the atria and into the ventricles. And if that starts happening, you get less blood flow coming into the atria and into the ventricles, you reduce your preload, your ventricular filling, and that can lead to a drop in stroke volume and a drop in cardiac output. We'll talk about all the complications that you can see here. But again, to take away from all of this, what is the big theme that I need you guys to take away from this? So what is the overarching differences truly to understand cardiac tamponade? Again, here's what you have to remember. When actual fluid or blood is accumulating within the pericardial cavity, what you usually want your actual pericardium to do is you want it to naturally undergo this stretching process. And the whole purpose of the pericardium stretching is to accommodate that actual fluid, whether it be blood or serosanguinous fluid, and in order to be able to do that, to accommodate all that volume. Now, what happens if the actual amount of the fluid, whether it be blood, whether it be serous, whether it be serosanguinous, it develops rapidly, or you develop it not just rapidly, but the volume of fluid that's accumulating in this pericardial cavity is just insane. How does this lead to tamponade, and how is that different from an effusion? Well, if it develops rapidly, this inhibits the stretch process. If you have blood that rapidly accumulates into that pericardial cavity quickly, your pericardium doesn't have enough time to stretch and accommodate that inflow of blood. And so because of that, it won't stretch, and instead it'll squeeze down and compress on the heart. When it squeezes down and compresses on the heart, you reduce the ventricular filling process. And if you reduce the ventricular filling process, what does that result in? If I reduce my ventricular filling process, that is eventually going to drop my cardiac output, and this can lead to cardiogenic shock. The other thing is if the volume is so high, there's so much fluid that's in the pericardial cavity that the pericardium just can't stretch anymore. It's like, dude, I'm at my max stretch, I can't do anymore. If that happens, that stretch is inhibited and it can't actually accommodate that fluid, and because of it, it starts clamping down and squeezing in the heart, reducing ventricular filling and reducing cardiac output. In this scenario, this is tamponade and no longer an effusion. Now that we understand that, let's talk about more on the clinical manifestations and physical exam findings of someone with tamponade. All right, so let's talk about the clinical manifestations and the physical exam findings behind someone with tamponade. So the overarching theme here is that these patients have high intrapericardial pressure, right? So the pressure within their pericardium is way too high, whether it be because it rapidly accumulates and you don't give time for the actual fluid in the pericardial cavity to accumulate and the actual pericardium time to stretch. If that happens or it rapidly occurs, again, what will happen? Pericardium doesn't have time to stretch and accommodate that actual fluid, and the pressure in the pericardium will start increasing its exertion on the actual heart. or the volume accumulates in such a large amount that the pericardium can't stretch anymore, and so it actually starts exerting its pressure on the heart. Regardless, that's the issue, is that there is high intrapericardial pressures. That high intrapericardial pressure does what? It squeezes on the heart. When it squeezes on the heart, it increases the pressure inside of the actual ventricles. So imagine them being squished. Now, if you imagine these being squished, I guess it would be easy to think about it like this now. Look how tiny now this actual ventricle is, because you done squished that bad boy to where it's going to be so hard for you to be able to get any kind of fluid, or blood, into these actual ventricles. So with that process, this significantly reduces the ventricular filling. When you reduce the ventricular filling, what do? You reduce your end-diastolic volume, right? You reduce the amount of blood that gets into the heart during the diastolic process. So blood coming from the superior vena cava and inferior vena cava into the right side of the heart will be drastically reduced. And so if you reduce your end-diastolic volume, you drop your preload. If you drop your preload, you drop your stroke volume, you drop your stroke volume, you drop your cardiac output. And so you can have a low cardiac output. And particularly, think about it like this. Say that there's a less amount of blood that's getting into the right ventricle. Pretend you're a little red cell. That means less blood is getting pumped through the pulmonary circulation, less blood going through the pulmonary circulation and back to the pulmonary veins, less blood coming into the left atrium, into the left ventricle, less blood being pumped out of the left ventricle and into the arterial circulation. So this can lead to significant hypotension, systemic hypotension. That's a problematic issue. What is that called whenever the blood pressure, like your mean arterial pressure, drops significantly because of that low cardiac output? And it's because of the heart that's the problem. This is called cardiogenic shock. And this is one of the feared scenarios of someone who develops cardiac tamponade, is that they can severely drop their actual blood pressure, their mean arterial pressure, and quickly go into cardiogenic shock. What can this manifest like? Well, think about it. If you have less perfusion, less blood is actually getting perfused into your arteries of your upper extremities, you'll have cool and clammy extremities. Cool and clammy extremities of the lower and the uppers. Okay, you'll have a palish type of appearance. Those are some of the things that you may actually see. So again, cardiogenic shock is the fear and the scary concern with this condition. You know what else is really interesting that can happen with this condition? It's really, really interesting. You know what the most common clinical feature is for these patients? Well, actually, before we do that, here's another thing I want to think about. When you drop your blood pressure, your systemic blood pressure drops, there's something else that happens. So obviously, one of the things that we'll see is hypotension. So hypotension will be one particular feature. What's the other feature? Whenever your blood pressure drops, you know what that does? So whenever you have a low mean arterial pressure, a low mean arterial pressure will trigger something called a reflexive tachycardia. In other words, you're going to try to increase your heart rate, right? So what happens is your blood pressure drops. Your baroreceptors, right, and your baroreceptors within the carotids and the baroreceptors within the aortic arch, they pick up on that actual low pressure. They send the information to your medulla. Tells your medulla, hey, the blood pressure is low. Medulla says, don't worry, buddy, I got this. I'm going to send increased sympathetic outflow. It sends an increased sympathetic outflow to the heart to increase heart rate, to increase contractility, and it also causes your vessels to clamp down more. The problematic issue, though, that we actually see is this increase in heart rate. And so not only will they have hypotension, but they may have evidence of tachycardia. And again, because they're not perfusing their organs very well, the manifestations of hypotension may be cool, clammy upper and lower extremities, as well as a palish type of appearance. Okay, those are the things I want you to remember for that. The second thing, so obviously if you walk into the room, you see a patient with hypotension, you see a patient with, what else? Tachycardia, potentially could be a manifestation of cardiac tamponade. Here's the other thing that's really interesting. You know what the most common clinical manifestation is of someone with cardiac tamponade? The most common clinical features is actually dyspnea. That is the most common, chief complaint. And the reason why is super weird, okay? Here's why. When a patient has cardiac tamponade, and you take a deep inspiration, so you take a breath in. So during inspiration, what happens is this will decrease your intrathoracic pressure. Okay, because the whole point is that if you're trying to take a breath in, your thoracic cavity volume increases. If your thoracic cavity volume increases, the pressure in your thoracic cavity drops. And the whole purpose is to suck air into your lungs. You know what else happens? If your intrathoracic pressure is lower because you're taking a breath in, it actually sucks blood from your inferior vena cava right up into your right atrium and sucks blood from your superior vena cava right down into the right atrium. So it increases your venous return. So during a deep inspiration, imagine blood just jetting down into the right ventricle from the superior vena cava and jetting down into the right ventricle from the inferior vena cava. So there's going to be an increase in inflow. When there is an increase in right ventricular inflow, the volume of the right ventricle increases. And you have a higher preload, right? So you have a higher preload, and then potentially, if you have a higher preload, you can push more blood out. And so you have a higher end-diastole, higher preload, higher stroke volume, higher cardiac output. So that's one particular thing. So what happens is these patients, they have dyspnea, and it's because they're trying to augment their venous return to try to up their blood pressure. Because every time they take a breath in, they suck blood into their heart. And that's a very interesting type of process. And so one of the big things to remember here is that these patients often will present with dyspnea, shortness of breath, but what they'll look like is they'll actually be taking in deep breaths and maybe more frequently, because every time they breathe, they suck blood into the right side of the heart and increase their venous return to the right side of the heart. So the whole point of this is to increase your venous return. And what happens is that might help a little bit to increase their blood pressure as a compensatory mechanism. So it's a really interesting way of describing one of their awesome, very key clinical features. So we may walk into the room, see that their actual vital shows hypotension, reflexive tachycardia, and whenever they take a deep breath in, their blood pressure actually maybe be a little bit more stable, or you just notice that they're taking more frequent breaths. Dyspnea, think about it in the back of your head. Oh, maybe they're dyspneic because they're trying to augment their venous return. Okay, what are some other key signs to think about? You know what else is very interesting? In these patients, they have this high amount of intrapericardial pressure, right? And it's squeezing on the heart. The problematic area tends to be the right ventricle. And the reason why the right side of the heart gets more impaired is why? Compare the thickness of the left side of the heart versus the thickness of the right side of the heart. Which one's thicker? The left side of the heart. So if the pericardial pressure is higher here, it's still going to have to push on. It might be equal intrapericardial pressure, but it's going to have to push against a thicker myocardium on the left in comparison to a thinner myocardium on the right. So the right side of the heart tends to be collapsed a little bit more easily in comparison to the left side of the heart. So regardless, the intrapericardial pressures are high. It's going to start trying to collapse the right side of the heart. If the right side of the heart now, let's imagine here that I make this right side of the heart really small now. Right? So look here, look, I'm gonna make this bad boy real small. So now it's gonna be really hard for blood to flow into the right ventricle from the right atrium. And so because of that, it's actually gonna have less blood flow that's being able to get returned into the right ventricle. So what happens is in these patients with cardiac tamponade, they have decreased venous return, right? Venous return, so you have decreased venous return. Whenever they have this decreased venous return into their right side of the heart, okay, this is going to cause a backup of blood. So this is causing the blood to back up. And when it backs up, it can back up into two places. It can back up into the right atrium and down through the inferior vena cava, or up through the superior vena cava. When it backs up into the superior vena cava, we can't actually see that. What we can see is a tributary from it. You know, what happens is from your superior vena cava, you have what's called the brachiocephalix. And then from the brachiocephalix, these actually branch out here and you have the subclavian and the internal jugular vein. What happens is, because of this actual intrapericardial pressure squishing down on the right side of the heart, when it squishes down on the right side of the heart, it reduces venous return into the right side of the heart. Blood backs up to the superior vena cava, brachiocephalix, and into the jugular vein. And it causes it to distend. And so one of the obvious manifestations here is that it'll back up via the superior vena cava. If it backs up the superior vena cava, it'll cause jugular venous distension via increased jugular venous pressure. There's more pressure that's in this side, and it commonly happens more on the right jugular vein than it will be visible on the left jugular vein. So that's one particular thing. If the blood backs up into the inferior vena cava and it goes via the inferior vena cava, this will actually dump into the liver. You know, the liver actually sits right here. So it'll go to the liver, and then it'll also go and actually into the lower extremities. And so what you may actually see in these patients is you may see what's called hepatomegaly, right? They may have kind of a swollen abdomen. They may even have ascites due to the fluid backing up around the liver and the GIT, or it may back up into the lower extremities and cause swelling of the lower extremities via what's called pedal edema. It may be pitting edema. So these are some of the particular signs that you may see, but one of the big ones, the highlighting ones, is this jugular venous distension via increased jugular venous pressure. Another one that is a big one is hypotension. That tends to be a very common manifestation in these patients, as well as a reflexive tachycardia. And dyspnea seems to be a very, very common manifestation due to them augmenting their venous return. What else can they actually have? Another particular feature that these patients also have is imagine having all this fluid in your actual pericardial cavity. And every time your heart makes the particular sounds, it makes your S1 and your S2 heart sounds. That sound has to travel through the actual ventricular chambers, through the myocardium, through that big pericardial cavity now, filled with maybe lots of blood or fluids. That is going to decrease the intensity of the S1 and S2 heart sounds to where they maybe sound muffled, or we can use the term distant. This is a very, very important thing because in textbooks, there is a very specific triad where if a patient has, and this triad is called Beck's triad. Now, Beck's triad says if you have hypotension, high jugular venous pressure via jugular venous distension, and decreased heart sounds, these may be indicative of someone having cardiac tamponade, okay? However, in true reality, maybe 25% of patients actually exhibit this clinical manifestation, but it's easy to remember for your boards. So far we have cardiogenic shock as the concerning finding, hypotension, tachycardia, dyspnea to augment their venous return, jugular venous distension due to less venous return into the heart because the intrapericardial pressures are squeezing on the right side of the heart mainly, and backing up into the inferior vena cava, causing hepatomegaly, ascites, pedal edema. And then again, distant heart sounds because of having all that fluid that the heart sounds have to travel through. You know what else? What's a very common cause of someone having pericardial effusions, my friends? Pericarditis. So if they have pericarditis and their pericardium is inflamed, maybe you have muffled or distant heart sounds. But if maybe there's not as much fluid, what else could you potentially hear? You may hear a friction rub, right? So think about that as well. There may be potentially a friction rub present, which is seen in patients with pericarditis. Okay. Here's where the money is, and this is where I actually really think that you guys really need to understand this. There's another clinical feature called pulsus paradoxus. So let's talk about that. All right, so another particular finding that also supports the diagnosis of cardiac tamponade, especially in the physical exam findings, is something called pulsus. So sometimes we actually just call it pulsus, but it's pulsus paradoxus. There's a couple conditions that may have this as well. Obviously, someone with severe COPD, right ventricular dysfunction from pulmonary hypertension, or they have a massive pulmonary embolism. There's other conditions that can cause this as well. However, in this context, if you see some of these findings that we've already talked about and pulsus paradoxus, you should have a high degree of suspicion for cardiac tamponade. So here's what I want to explain. Okay, when we look at someone's pulse, okay, and you look at it, the best thing to do is to look at this in what's called an arterial waveform. So sometimes if you can actually get what's called an arterial line. So let's say that this is a normal patient and we're looking at what's called an arterial line waveform, an A-line waveform. When you look at this, let's say that we take a normal blood pressure in these scenarios. So 120 systolic, 80 diastolic. What will happen is you'll see something like this. Here's your waveforms, right? Whenever you're actually taking normal breaths, so taking a breath in and breathing a breath out, there is changes in your cardiac output, but they're even more significant there's significant resporophasic changes in your blood pressure in patients with cardiac tamponade. We'll explain what. But here's what happens normally. Normally, when you're taking a deep breath in, what did we say happens to the intrathoracic pressure? It drops. When your intrathoracic pressure drops, you suck air in and suck blood up into your heart. Well, you don't suck air into your heart, but you suck air into the lungs and you suck blood up into your heart. When that happens, blood return into the heart increases. That's the only time that you actually are getting a decent amount of venous return, even with having someone with cardiac tamponade. But once you have this venous return increase, you get a decent amount of blood that accumulates in the right ventricle. Now, normally what happens is you get a very small, so blood will actually come into the right ventricle enough that it'll just a very, very small amount shift the septum, very, very minimal, shift the septum to the left ventricle. And when it does that, it doesn't interfere so much to where the amount of blood that's getting into the ventricle and the amount of blood getting out of the ventricle is reduced in normal patients, okay? And so because of that, you get a very, very mild, very small reduction in blood flow coming in and blood flow going out of the ventricle. So let's say that you take a patient here, and let's say at this point in time, they're expiring. So this is expiration. Then they take a breath in. When they take a breath in, they suck a lot of blood into their right side of the heart. When they suck a lot of blood into the right side of the heart, they shift their septum a little bit in a normal patient to the left. Minorly reduce inflow and minorly reduce outflow. Enough that it might cause a very small change in their blood pressure. So in this phase, this is inspiration. So this is during inspiration, and in this phase, this is during expiration. Okay? It's a very, very mild, very, very small reduction. Okay? And then again, the same thing would happen if they went into an expiratory phase. They would actually go here. Now, I guess the question that you should ask is, why does it actually kind of increase or stay the same, like that normal range, or go up during expiration? It's the exact opposite. During expiration, what happens? During expiration, your intrathoracic cavity pressure actually increases, and that squeezes blood into the left side of the heart. And during expiration, if you're squeezing lots of blood into the left side of the heart, you get an increase in venous return to the left side of the heart to where it actually may shift the septum just a tiny bit to the right. So again, during expiration, intrathoracic cavity pressure increases, you squeeze blood into the left side of the heart, you get a small increase in venous return to the left side of the heart to where it shifts the septum just a teensy little bit to the right. When it shifts it that way, you get maybe more blood that can come into the left ventricle and more blood to exit the left ventricle. And so if that's the case, if more blood is leaving the actual left ventricle, during expiration, the pressure should be higher. And so that's your normal resporophasic changes in your blood pressure. So now we get how this happens during a patient normally, a normal patient without cardiac tamponade. And we get the normal resporophasic changes in the arterial pulse, okay? Now, imagine a patient with tamponade. A patient with tamponade, they have high intrapericardial pressures, right? So this pressure is high that it's gonna start squeezing on the heart, trying to reduce the venous return. Okay, it's going to try to reduce the venous return. What happens in a patient with this cardiac tamponade is, let's say that we go off of this same situation here, right? Same situation, during expiration, their pressures are in this range. They're relatively better on the left side, right? So we know during that process, that's going to be the same. Here's where it gets interesting, okay? In these patients, they have high intrapericardial pressure. And then where's the pressure worse? Is it on the right side of the heart or the left side of the heart? It should be more on the right side of the heart. So the pressure that's being exerted on this side is worse just because the right ventricle and the right atrium are thinner. Now, you take a deep breath in. You try to increase your intrathoracic cavity. Whenever you take a deep breath in, you try to decrease your intrathoracic pressure, right? And the whole point of taking a deep breath in is to decrease your intrathoracic pressure, that you suck air into your lungs and suck blood up into your heart. In this process, you want to suck blood into the actual right atrium or right ventricle. But the pericardial pressure is so high that it's squeezing on this right ventricle and saying, no, buddy, there's not a chance in this world you're going to get as much blood in here. And so because of that, it doesn't allow as much blood. And what happens is whenever the blood gets into this actual right heart, it tries to distend just a little bit, but it can't distend against this actual pericardium because the pressure's too high. So guess where it decides to push on? It pushes on the septum very significantly. And when it pushes on the septum, it shifts the septum and really, really significantly reduces the inflow into the left ventricle and reduces the outflow from the left ventricle to the point where the pressure will really significantly drop from the actual left ventricle. And so here's what you may see. You'll see them actually expiring and their pressure being normal. And then whenever they take a deep breath in, guess what? Their pressure is really low. And then again, this is during what phase? Inspiration. And then again, what happens during expiration? Just to be repetitive. During expiration, you're trying to breathe air out. So in order to do that, your intrathoracic cavity pressure has to rise. When your intrathoracic cavity pressure has to rise, what happens? You're trying to get blood out of the heart. And so this causes more blood from the left ventricle to get pumped out of the heart. And the reason why is you're trying to cause blood to get sucked into the left side of the heart. And when you cause blood to get sucked into the left side of the heart, it bows the left ventricle into the right ventricle, opening up the cavity of the left ventricle, more venous inflow, more venous inflow, and more blood outflow. And so because of that, during expiration, the pressure will look like this. Now, this difference when you're going from expiration into inspiration, whenever the actual pressure difference is greater than or equal to 10 millimeters of mercury, this is considered to be pulsus paradoxus. Okay? This is considered to be pulsus paradoxus. So that is the difference here. So pulsus paradoxus is whenever somebody has a drop in their systolic blood pressure greater than or equal to 10 millimeters of mercury during inspiration. And this can be a very particular finding for patients with cardiac tamponade. So, to summate, we have a patient who is hypotensive, tachycardic, worrisome findings of cardiogenic shock. They're dyspneic because they're trying to augment to increase their actual venous return to the right side of the heart. They have jugular venous distension via high jugular venous pressure. They have hepatomegaly, ascites, pedal edema. They have a muffled or distant type of heart sound with presence of maybe Beck's triad. On top of that, they also have evidence of pulsus paradoxus where their systolic blood pressure drops more than or equal to 10 millimeters of mercury during the inspiratory phase due to causing a significant septal shift during inspiration from the right ventricle into the left ventricle, reducing blood flow into the left ventricle and reducing outflow of the left ventricle. My friends, that covers the clinical manifestations and physical exam findings. Now let's talk about the diagnosis. All right, so what are some particular diagnostic things that we should be thinking about in a patient with cardiac tamponade? Well, first off, you want to be thinking about the particular causes that we talked about. So again, if someone has any of those risk factors that we talked about for hemopericardium or any of the risk factors that we talked about for these serous or serous sanguinous effusions. Then if a patient comes in, you're looking at their vitals and they show hypotension, they show a high tachycardia, you see jugular venous distension, you're listening to their heart, and you hear decreased or muffled heart sounds. You notice that they're complaining of dyspnea or that they're maybe short of breath and breathing a little bit faster because they're trying to augment their venous return. You're looking at their arterial line waveform and you're seeing pulsus paradoxus greater than or equal to 10 millimeter mercury drop in their systolic blood pressure during inspiration. You should be thinking, okay, what kind of things do I need to look for right away to rule out cardiac tamponade? Well, the first thing you should do is get a 12-lead EKG, okay? Because these patients may also present with chest pain as well. More commonly, they present with dyspnea though. And either way, if someone presents with dyspnea, you better get an EKG as well. So you get a 12-lead EKG on these patients. What may it show? Well, we already know. One of the things is that they may have a reflexive tachycardia. So that may be one thing. This may be sinus tachycardia. This may be atrial fibrillation because cardiac tamponade can definitely worsen if someone's already present atrial fibrillation. So you're going to see an increase in their heart rate. So you may see evidence of tachycardia. But here's something else that would be very interesting, okay? In these patients, okay, think about this. You have, very, very interestingly, right, whenever somebody has a ventricular depolarization, during ventricular depolarization, they have a mean QRS vector that points this way, right? Generally towards leads 2, okay, towards the positive electrode of lead 2. Whenever it does that, the electrical vector, the mean QRS vector, as it's moving toward the positive electrode of lead 2, it'll produce an upward deflection, right? We know that. In a patient who has a lot of fluid, let's say there's lots of fluid, there's maybe blood, there's serous, there's sanguineous fluid, and what's happening is the electrical activity has to move through the ventricles, through that large pericardial fluid in the pericardial cavity, and then to the chest wall. What happens is anytime there's air, there's fluid, there's blood, there's anything like that that's occluding or restricting the electrical activity getting to the electrodes on the chest, that's going to lower the QRS voltage. And so in this case, these patients, because of the pericardial fluid, this can actually decrease their QRS voltage. So they may have low voltage QRS complexes in combination with tachycardia. All right, what else is another particular finding we can see in patients with cardiac tamponade? This one's really interesting, okay? When you get a pretty decent effusion, right? So lots of fluid accumulating in this darn pericardial cavity. What happens is the heart kind of like, it swings back and forth. You know, imagine like the apex of the heart swinging from left to right to left to right whenever it's going through these actual cardiac cycles. The interesting thing with that is that our lead 2, like, you know, if we use this as an example, the positive electrode is going to be in that kind of like position right here, right? It's designed to be able to pick up the mean QRS vector that's directed towards it. And in this position where it's in the normal position, kind of tilted a little bit to the left, that vector will go like this, okay? But when it swings this way, so imagine I'm in the pericardial cavity and here's my vector, and then I'm contracting and I'm swinging this way now. Now when I swing this way, now the mean QRS vector is pointing in a different direction, maybe a little bit away from the positive electrode of lead 2. So now my vector is pointing this way. So what happens is this causes the height of the actual R waves, or the height of the QRS complex, to be bigger when it's in this configuration and smaller when it's in this configuration. And so you get something like an alternation in QRS complexes, where they'll be large, and then you'll have another one and it'll be like this. And then you'll have another one and it'll be like this. And then you'll go back to it again and it'll be a little baby one. And you get the point. You see these alterations between the electrical activity, particularly the QRS voltages, as we go throughout the cardiac cycle, where some are smaller than the other ones. Okay? And when that's happening, this right here is called electrical alternans. And this may be a particular finding that you see in someone with what? Cardiac tamponade. So for EKG findings, you may see tachycardia, low QRS voltage, and electrical alternans. Okay, what are some other tests? Well, a patient may again present with dyspnea. Sometimes dyspnea is an indication for an EKG and also for a chest x-ray. Is an EKG going to diagnose cardiac tamponade? No. So really, is this like an absolute necessary test? No. It'll help you rule out some other things and potentially key in some adjunctive tests to say, ooh, this could be cardiac tamponade, but it's not going to be the true diagnostic test. Is a chest x-ray going to tell me I have cardiac tamponade? No, it's not really going to do that. It may cue you in to say, hey, I got to look at the heart a little bit more, but it's not going to be diagnostic completely. If I got a chest x-ray, what would it show though? If I got a chest x-ray, I may see an enlargement of the heart. So there may be some signs of like cardiomegaly or an enlargement of the cardiac silhouette. And so there may be some type of like, sometimes we give it like a very specific term where it kind of looks like a water bottle, like a water bottle sign. And that is because whenever you have all this fluid within the pericardial cavity, it literally makes it like a weird configuration. So sometimes if we got a chest x-ray, it may show cardiomegaly or like what's called an enlarged cardiac silhouette with a water bottle sign. But again, still not diagnostic for someone with cardiac tamponade. What would be some tests that would be good for cardiac tamponade? All right, so what would be some good cardiac imaging then that I could actually help myself determine if this patient has cardiac tamponade? It would be an echo. An echo is truly going to be the best test that you could get here. So what can an echo tell me? Well, if I do an echocardiogram, what are some of the things I'm going to look at? I want to look at a couple things first right away. First one is there an effusion? And generally, in order for you to have cardiac tamponade, you have to have an effusion. It doesn't matter about technically the volume, because again, sometimes you can have a large volume of fluid within that pericardial cavity, and it still isn't enough to start actually compressing the heart and reducing cardiac output. What's a matter is actually if it rapidly accumulates or if the volume is truly at the largest point where the pericardium can't stretch and accommodate that volume anymore, then it will start to actually reduce the actual cardiac output. But you need an effusion, right? So that's the first thing. The next thing is think about this. If the pressures from the intrapericardial pressure is high, it's going to start squeezing again on the heart. But remember what I told you, which side of the heart, unfortunately, is more likely to be hit? The right side of the heart, right? That's the significant one, because the right side of the heart, the myocardium, is just thinner. So because of that, the right-sided pressures are going to be, again, a little bit higher. So what happens here is very interesting. Whenever the blood is coming into the ventricles during the diastolic period, what happens is whenever blood's coming into the ventricles, if the pericardial pressure is so high, it's going to squeeze on the ventricle and reduce the amount of blood that's coming into the ventricle during diastole. And so we can see what's called right ventricular collapse. Also, if blood is trying to come from the superior vena cava or inferior vena cava into the right atrium during diastole, again, which side is the pericardial pressure higher on? The right side of the heart. So it's going to squeeze on the right atrium harder, especially whenever it's trying to accept blood during diastole, and that'll cause the right atrium to collapse. And so because of that, one of the things that we would look for is right atrial collapse during diastole, or right ventricular collapse during diastole. So that's another interesting thing that we would look for. So when we get the echo, we want to see, is there an effusion? Second thing what I want to look for is the right atrium, because the pericardial pressures are so high, collapsing the right atrium when it's in diastole? Is the pericardial pressure so high it's collapsing the right ventricle during diastole? And you know what else I want to know is, because the right side pressures are so high, venous return is being reduced right into the right side of the heart. Okay, yes, it is increasing a little bit during inspiration, but regardless, the pressures on the right side of the heart are higher, and so it's going to cause blood to backflow into the superior vena cava and the inferior vena cava. If I took and actually put an ultrasound on someone's inferior vena cava to see if it was big or small, what would also be indicative if I have high right atrial pressures? So if I went and I took and looked at that actual inferior vena cava of these patients, it would be dilated. So it would be plethoric. So another particular finding would be what's called a plethoric, just meaning that it's a big old fat IVC. And that's because there's high right-sided pressures. So a plethoric IVC. Okay, so again, effusion. We got collapsing of the right sides of the heart, right atrium, right ventricle during diastole, and a plethoric IVC. What else? Remember I told you that during inspiration, you put the echo on there and you look at the heart. You have them take a breath in. When they take a breath in, what will happen? Blood will come from the superior vena cava and inferior vena cava and into the right side of the heart. When it gets into the right side of the heart, it has to try to accumulate and wants to stretch to accommodate that. Can it stretch against this pericardium that's not letting it? No. So what does it do? It pushes on the septum and bows and shifts the septum into the, what? Left ventricle during the diastolic filling process. And so another thing you'll see is you'll see what's called a septal bounce or a septal shift during diastole. And which way will it be shifting from? And again, septal shift during diastole, and particularly, this is during the inspiratory phase, inspiration. This will happen where its septal shift is from the right to the left. So there'll be a bowing of the interventricular septum from the right side to the left side during diastole when they take a breath in. When they take a breath in, what happens to the venous return? It increases. On what side of the heart? The right side of the heart. So they take a deep breath in, intrathoracic cavity pressure does what? Decreases. If the intrathoracic cavity pressure decreases, what does that try to do? Suck air into our lungs and suck blood up into the heart. When it sucks blood into the right side of the heart, blood is going to start blasting across that tricuspid valve more during inspiration. So we call this respirophasic changes in transvalvular velocities. There's not a chance I'm going to write that. All I want you guys to know is that there is an increase in blood flow across the tricuspid valve during inspiration. And then subsequently, because you're actually causing that septal shift, so whenever you take a breath in, you suck blood across into the right side of the heart, flushes down into the right ventricle, right? You shift the right ventricle towards the left ventricle, the septum, and then you know what else happens? You reduce the inflow of blood from the left ventricle, from the left atrium into the left ventricle. So what would happen to the blood flow across the mitral valve during inspiration? It would subsequently decrease because you're shifting the septum inwards, which is decreasing the cavity size and reducing the inflow from the left atrium into the left ventricle. So you'd have increase in blood flow across the tricuspid valve during inspiration, and subsequently you would have, let's just write it, you would have a, what else? A decrease in blood flow across the mitral valve, again, during inspiration. So these are the things that I want you guys to know about this echo findings in a patient with cardiac tamponade. This is the highest yield stuff. So we've gone through, we had the patient get an EKG, a chest x-ray, we got an echo. Echo is definitely going to be the gold standard test, my friends, for diagnosing cardiac tamponade in combination with their clinical findings. You know what else? Sometimes cardiologists will say, not tamponade yet. You may have all these findings. The true way to see is this cardiac tamponade or not is, let's say that they were hemodynamically unstable. You suck some of that actual, you tap it. You tap and pull blood or fluid, whatever it is, from the actual pericardial cavity. And after you do, you pull off, so you pull fluid. If their hemodynamics improve after pulling fluid off via pericardiocentesis, you've diagnosed cardiac tamponade. So that's truly, when it comes down to the clinical world, how we actually diagnose a patient with cardiac tamponade is we can go through this whole thing and say, their echo suggests it, their physical exam and clinical findings suggest it. I think that they have tamponade. Well, the true way is, okay, let's tap it, let's pull fluid off. If their hemodynamics improve, it was cardiac tamponade. If it doesn't, you got to go searching off something else. Okay? Now, here's the thing. If someone has a lot of fluid within their pericardial cavity, right, we definitely want to do a pericardiocentesis to be able to pull off and therapeutically treat them. However, during that process of we're pulling off some actual fluid, whether that be blood or serous sanguineous fluid, so again, what is this called here? A pericardiocentesis. The benefit to this is that it's going to diagnose someone with a cardiac tamponade. Why? Because if I pull off fluid and they improve hemodynamically, I definitely diagnose someone with cardiac tamponade. But also, it can determine the etiology. So what can I do? If I pull off this pericardial fluid and they have improvement in their hemodynamics, I want to figure out why the heck they had cardiac tamponade. So I can utilize that fluid and send off all the different tests. Maybe I send off a gram stain. Maybe I send off cultures. Maybe I send off cytology. Maybe I send off different proteins. Maybe I send off an acid-fast bacillus stain. All this other stuff, and I can go figure out what the heck was the cause of this thing. But the benefit of actually the diagnostic and therapeutic information behind this is a pericardiocentesis is diagnostic, but it's also the therapeutic treatment. So when we actually have a patient in cardiac tamponade, we truly want to diagnose it. Guess what? We can do both. We can diagnose them and treat them. If we pull off fluid, hemodynamics improve. I diagnosed it, and pulling off that fluid actually improved their hemodynamics, which actually gets them out of cardiogenic shock. So that's the benefit of this. So that's why I would say when it comes down to it, tap it And if it improves, you've diagnosed it. And on top of that, you can then go and figure out the etiology of what was causing it. Okay, now that we've diagnosed cardiac tamponade, my friends, we have to treat it. So let's talk about the treatment. All right, so when we have a patient with cardiac tamponade, okay, obviously we already know what the definitive treatment is. It's a pericardiocentesis. And then eventually maybe they need a drain. But until then, until we've actually gotten that all started, okay, we got our cardiology team coming and they're like, all right, buddy, we're on our way. We'll get ready to go ahead and tap that pericardial cavity and pull some of that fluid off, and we're gonna be heroes. Until then, you gotta keep your patient alive. They're in cardiogenic shock. So they're hypotensive, they're tachycardic. They are at risk of going into cardiac arrest. How do I stabilize them in the interim until we can get that ultimate treatment, which is pulling off the fluid from the pericardial cavity? I have to defend the map at all costs. The mean arterial pressure is my goal. So how do I do that? Well, the first thing that we can do is we can consider intravenous fluids, right? So the first thing I would say is, let's try to be able to give them intravenous fluids. The whole idea behind giving the intravenous fluids is what? We can give different things. We can give lactated ringers. You can give normal saline. I would say try to stick on the edge of lactated ringers. But when you give them the fluid, the whole goal is that you're trying to augment their blood volume, to augment their blood pressure, right? If you give them fluid, you're trying to increase the venous return into the right side of the heart. If you increase their venous return, so if you're trying to increase blood volume and subsequently increase in diastolic volume so that you can increase their stroke volume, so that you can increase their cardiac output and their blood pressure. That's the whole process here, right? However, there's a certain point where fluids are no longer beneficial and sometimes problematic. So I would say give fluids, and when I say that fluids probably should be stopped is when I see evidence, I would say stop giving IV fluids when you see something called a Kussmaul's sign. So a Kussmaul's sign is kind of a way of telling me, hey, my right ventricle and right atrium are not going to accept any more fluid, so giving us more fluid isn't going to help you. It might even potentially hurt you. Because you know what a Kussmaul's sign is? A Kussmaul's sign is when the jugular venous pressure stays the same or rises even during inspiration. What's supposed to happen to the jugular vein, the blood column there, whenever you take an inspiration? You take a deep breath in, your intrathoracic cavity pressure drops. What do? You suck blood into the heart. Naturally, it should drop. But if it stays at the same or it even rises a little bit, that tells me that blood is just not going into the right atrium and the right ventricle. And so there is just not very much venous return. If I give them more blood, it's not going to benefit them whatsoever. So I'd stop giving IV fluids when I see a Kussmaul's sign. That's the first thing I do. So I give them fluids, and I would just keep an eye on that jugular vein, maybe even throw an ultrasound on it too. And if I ever see the jugular vein distending at a point higher than what it should be during the inspiratory phase, I know, oh, stop giving fluids. The next thing I would say is, okay, I give my fluids, I also should support their actual vasculature in their heart. So I may give certain types of pressors. And so this is maybe where I give drugs such as norepinephrine and maybe epinephrine. But more likely norepinephrine is going to be the preferred here. And what will happen is norepinephrine or epinephrine will act on what's called the alpha-1 receptors on our vessels. When they act on these receptors, what do? They cause the vessels to undergo vasoconstriction. When you vasoconstrict them, what do you do to your resistance? You increase your systemic vascular resistance and subsequently increase your mean arterial pressure. So that's one way I can have them cause vasoconstriction. The second way is that we also have what's called beta-1 receptors on our heart. And what happens is when epinephrine and norepinephrine bind onto the beta-1 receptors on the heart, particularly on the nodal system, what's that going to do to your heart rate? Increase your heart rate. If they act on the beta-1 receptors on the contractile portion of the myocardium, that's going to increase their contractility. So if I increase heart rate, I increase contractility, what do these two things do? Well, eventually it increases my stroke volume if I increase contractility. And if I increase heart rate and stroke volume, that increases my cardiac output, and I increase my mean arterial pressure. And that's going to support their blood pressure in the interim. So what I will do is I will give them fluids, stop when I see a Kussmaul sign, start them on a pressor, titrate that pressor towards a particular MAP goal. Generally, we say a MAP greater than 65 is enough to perfuse your organs. Once I've done that, what is another thing that I'll do to treat these patients? It's all about that thoracic cavity pressure, baby. So I have to do everything possible to not only defend their MAP via fluids and pressors, but I have to try my best to do what to the intrathoracic pressure? Reduce it. Why? What does a reduction in intrathoracic pressure do? Sucks blood into the heart, increasing venous return. If by any situation I increase the intrathoracic pressure, I reduce the venous return to the heart. Do not want to do that. So I know this sounds super scary, and I know it does. If a patient is dyspneic and they look like they're in shock, what would your natural inclination be? To intubate these patients. For the love of goodness, do not intubate these patients. They may be staying alive right now because their inspiratory efforts are what's actually keeping their blood pressure up. Because every time they suck air in, they actually increase their venous return and keep their blood pressure high enough to survive. If you intubate them, you take away that actual ability for them to suck air in, because whenever you have to intubate somebody, you have to paralyze them. So you paralyze them, and when you paralyze them, you reduce their muscle effort to be able to inspire air in. And so that's problematic. Okay? The second thing is that you want to, let's say that you did intubate them. If you intubated them and they survived, you don't want to keep the pressure in the airways higher, especially during expiration. And this is called PEEP, your positive end expiratory pressure. Believe it or not, your right side of the heart hates PEEP, because whenever your PEEP is high, your intrathoracic pressure is higher. What does that do to the venous return to the right side of the heart? It reduces it. So in these patients who are intubated, what should you do to their PEEP? Keep their PEEP on the lower end of normal, because this will help to do what? Reduce the intrathoracic pressure so that you maintain some effort of venous return. Don't intubate, okay? And the whole purpose of that is that generally you have to kind of paralyze these patients. And if you paralyze these patients, there's a momentary time when they aren't actually having any inspiratory effort. There's no reduction in their intrathoracic pressure. No blood is actually getting returned into their heart, and their stroke volume drops, their cardiac output drops, and they arrest. So that's one of the big things to do, is to consider these two things. The ultimate goal, though, baby, is defend the MAP, give them fluids, pressors, keep their PEEP low. If they're intubated, do not intubate them if they need to be. And I know it sounds scary, but wait. And then eventually, the ultimate treatment is to drain that puppy. So let's talk about that. All right, so ultimately, we've defended the MAP with fluids, pressors. We've tried to avoid intubation, okay? On top of that, if they are intubated, we keep their PEEP on the lower end so they get some venous return. Eventually, cardiology will come. They say, okay, baby, give me that central line kit. They're gonna pop in via maybe a parasternal long axis view or a subxiphoid view, and they're gonna pop a needle into the pericardial cavity. When they pop that needle into the pericardial cavity, they're going to suck any of that fluid that's from the pericardial cavity and try to pull as much fluid as they can. And once they've done that, okay, via this process called a pericardiocentesis, again, this is the treatment. You pull off as much volume as you have to until their hemodynamics improve. Maybe they had a 50 milliliter effusion, but it rapidly accumulated. You pulled off 5 milliliters and oh, they're better. That may be all it takes, but you pull it off until they're hemodynamically improved. And here's the thing though. For a patient whose like left ventricle just exploded and they're just blasting blood into their pericardial cavity, or someone who has an aortic dissection, or someone that had some type of traumatic event, that you can do a pericardiocentesis, but guess what's going to happen? It's just going to reaccumulate. And so the problem with the pericardiocentesis is that it may temporize them. But the thing is that after you've done the pericardiocentesis, if it reaccumulates, then this is not going to help you. You need to move to the next step. And the next step is actually putting in what's called a drain. And you can do this via what's called a pericardial window. So what happens is maybe you're going from the parasternal long axis view, or you're going from a subxiphoid view, you poke your needle in, once you poke your needle in and you go ahead and you thread your guide wire into there, and then you thread like a, some type of pigtail catheter or some type of drain, you plug that drain. Sometimes you can do this under ultrasound guidance or CT guidance. The best thing to do is actually do it under surgery, where they actually open the patient up and do it. But in certain pinches, maybe you have to do this ultrasound guided or CT guided. Once you do that, you plug a drain up into the pericardial cavity. When you plug that drain up into the pericardial cavity, it's going to continue to keep sucking some of this actual fluid into this pericardial, into this actual drain. And this drain will keep pushing that actual blood or fluid into this actual drain. And then eventually the whole goal is to maybe figure out whatever was causing it. If it was an aortic dissection, we got to repair it. If it was a left ventricular wall rupture, you lived a good life. If there was some other thing where it was a coronary, bypass and we had to fix that, whatever it may be, go try to fix those issues and use your drain as kind of like an interim thing for the next 24, 48 hours. But this is the way that we would treat cardiac tamponade. Defend the map, fluids, pressors, stay away from intubating if possible. If you have to, lower their PEEP, drain the fluid via pericardiocentesis. If they have some issue where it's rapidly reaccumulating, pericardiocentesis isn't going to fix them. They need a drain to continuously keep draining that actual fluid or blood via what's called a pericardial window, and then use that as your way of temporizing them until you fix the underlying cause for their actual tamponade. Ninja Nerds, we done finished up the cardiac tamponade. I know it was a lot. I hope that you did understand it and made sense. Ninja Nerds, thank you, love you, and as always, until next time.